Good morning, everyone. Today's lecture focuses on an increasingly common challenge. In clinical psychiatry, what to do when antipsychotic augmentation for major depressive disorder specifically stops working. Commonly, we'll always prescribe an antidepressant, have partial response, and also consider antipsychotic augmentation. We'll explore how to define treatment failure, how to prescribe safely, and how to transition to alternative evidence-based strategies. By the end of this session, you should be able to identify inadequate response to second-generation antipsychotic augmentation, apply structured tapering and deprescribing methods, and select safe, rational next steps in treatment-resistant depression. So, understanding the role of antipsychotic augmentation, second-generation antipsychotics, SGAs, like aripiprazole, brexpiprazole, otherwise known as Rexulti, and quetiapine XR, are frequently used as augmentation for major depressive disorder that fails to respond to antidepressant monotherapy. They work through dopamine and serotonin modulation, improving motivation, affective range, and rumination control. However, prolonged use can lead to side effects such as weight gain, metabolic syndrome, akathisia, and emotional blunting. Clinicians must continuously evaluate whether their benefits outweigh their risks. FDA-approved agents and key differences. Currently, the FDA-approved antipsychotic augmentation for depression include Abilify, 2 to 5 milligrams daily, up to even 10 milligrams, effective within 1 to 2 weeks, and monitor for akathisia. Brexpiprazole, 0.5 milligrams to 2 milligrams daily, lower akathisia rate with similar mechanism. And quetiapine XR, 150 to 300 milligrams HS, beneficial when insomnia is significant, higher metabolic risk. And also Vraylar, 1.5 to 3 milligrams, a newer agent with a promising metabolic profile. Olanzapine/fluoxetine combination has strong efficacy but highest metabolic liability. Each agent's receptor profile determines its key benefits and its side effect vulnerabilities. So personalization is key. Recognizing when augmentation fails. Treatment failure can take 3 forms. So insufficient early signal, less than 20 to 25% improvement within 2 weeks at a therapeutic dose suggests low likelihood of ultimate success. Non-response, less than 50% improvement after 4 to 6 weeks. Continuing beyond this point often exposes patient to unnecessary side effects without any added benefit. Tachyphylaxis or poop out, loss of benefit after months of stability despite adherence and adequate dosing. Before labeling a case as a true treatment failure, always assess for pseudo-resistance, poor adherence, subtherapeutic dosing, drug-drug interactions, especially with cytochrome 2d6 or 3a4 inhibitors, and unrecognized bipolarity or untreated comorbid anxiety or PTSD. Next steps when augmentation stops working. When the antipsychotic augmentation no longer provides benefit, you have 4 main pathways. Switch augmentation agent, cross-taper between SGAs, for example, from aripiprazole to brexpiprazole to explore alternative receptor modulation. Optimize the primary antidepressant, maximize or switch the antidepressant class before abandoning augmentation entirely. Non-antipsychotic augmentation, consider lithium 0.6 to 0.8 as the level that you'd look for. T3 augmentation with 25 to 50 micrograms, mirtazapine or bupropion. Interventional treatments for refractory cases, such as using esketamine, RTMS, transcranial magnetic stimulation, or electroconvulsive therapy, ECT. The decision must always weigh symptom severity, comorbidities, patient preference, and prior treatment history. When and how to deprescribe. There are two major indications for deprescribing an antipsychotic used for depression. Medical risk outweighs benefit. Example, significant metabolic syndrome, QT prolongation, or emergent akathisia. Sustained remission, typically after 6 to 12 months of stability. The tapering protocol is reduce the dose by 10 to 25% every 2 to 4 weeks. Go slower for long-term users or those with prior relapse upon discontinuation. Monitor PHQ-9 scores and observe for insomnia, agitation, or depressive relapse. If withdrawal or relapse occurs, pause or revert to the previous effective dose. And this is how you would safely taper, to make sure when you discontinue and you safely taper, you do the dose reduction as slow as possible, to avoid seeing withdrawal symptoms as what you would see as clinical symptoms and confuse the two. Safety monitoring. While using or tapering SGAs, maintain active monitoring, metabolic, weight, BMI, and fasting glucose. Lipids, HbA1c, neurological, akathisia, or extrapyramidal side effects, use Ames or Barnes scale. Cardiac, QTc intervals, especially with quetiapine or olanzapine fluoxetine combination. Endocrine, prolactin if symptomatic. Document trends and intervene early with dose adjustments or switches to lower risk alternatives. Let's go over a clinical case study. Let's consider a real-world scenario that brings this all together. If you have a case of refractory depression with augmentation tachyphylaxis, for example, a 45-year-old female with recurrent major depressive disorder is on sertraline 150 milligrams daily for 1 year, Abilify 5 milligrams daily added 8 months ago with initial significant improvement. The presenting complaint over the last 2 months is depressive symptoms have returned, fatigue, anhedonia, emotional blunting, despite continued adherence. Mental status shows mild psychomotor retardation, restricted affect, intact cognition, but no suicidality. Labs show an HbA1c of 6.2, mild weight gain about 8 pounds, and akathisia symptoms emerging. This is a true example or a classical example of augmentation tachyphylaxis. Loss of prior benefit from the antipsychotic augmentation. First, rule out pseudo-resistance, confirm adherence, and check for the drug interactions and review thyroid and metabolic parameters. Given weight gain and emerging akathisia, the risk-benefit ratio now favors deprescribing, and the plan is to begin a gradual taper. Reduce aripiprazole from 5 milligrams to 3 milligrams for 2 weeks, then 2 milligrams for another 2 to 3 weeks before discontinuation. Another way to do it is to do a switch strategy. Transition to brexpiprazole or Rexulti, 0.5 milligrams if mild dopamine agonist support still needed, or trial lithium augmentation at low therapeutic range. Psychotherapy integration. Begin CBT with behavioral activation to maintain remission during taper. Monitor weekly a PHQ-9, metabolic follow-up at 3 months, and reassessment of sleep and energy using a structured side effect scale. The outcome, 8 weeks later. Let's see what happened. After 8 weeks, the patient successfully discontinued aripiprazole without relapse. PHQ-9 decreased from 17 to 8 after even lithium augmentation. Akathisia resolved, and HbA1c normalized to 5.7. She reports improved emotional range and motivation, key indicators of recovered dopaminergic tone. So, how do we decide? What's the algorithm summary? Here's the structured pathway we apply clinically. Verify parameters, dose, duration, and adherence. Assess response at 2 to 6 weeks. If non-response, switch augmentation or antidepressant. If remission greater than 6 months, consider deprescribing. Taper 10 to 25% every 2 to 4 weeks, monitoring for withdrawal or relapse. Replace or support with non-antipsychotic augmentation or interventional therapy if necessary. Here's some clinical pearls. Start low and titrate slowly. Pharmacodynamics differ across patients. Prioritize agents with low cognitive and metabolic burden. Always consider pseudo-resistance before switching or discontinuing. Antipsychotic augmentation is not lifelong. Plan an exit strategy at the start of treatment. Explain to the patient this may be only for 6 months or 3 months when starting an atypical antipsychotic for augmentation for depression. And be clear about that, because many times antipsychotics are more prone to tachyphylaxis than even our traditional antidepressants. In closing, remember, antipsychotic augmentation can be transformative in treatment-resistant depression, but it also must be continually reevaluated. When benefit fades or side effects emerge, structured deprescribing with transition to alternative strategies can prevent long-term harm while maintaining remission. The goal is not only to relieve depression, but to sustain recovery without unnecessary pharmacological burden.